Today I'm going to talk a bit about some of the myths around heart disease and highlight some of the key non-traditional risk factors for South Asian heart disease. I'm going to also then detail how the SSATHI clinic is personalizing the cardiac care for those South Asians, and how it's evolved starting within SSATHI, but also now expanding outside of SSATHI to something called CardioClick, where we've really tried to bring digital health into the equation to improve our outcomes. Lastly, I want to highlight the NEST program, which is our nutrition and lifestyle intervention program that pairs incredibly well with our medical program here at SSATHI to really add tremendous value to our results. And so what you're seeing here are 4 Bollywood actors and actresses who in just a very recent time period, 2022 to 2023, also had heart attacks. They survived, but now they are living with the damage from their heart that they incurred. So this is really a huge problem. When we look at the global picture, 17 million patients, this is somewhat outdated, the numbers are higher now, but 17 million patients approximately 12, 13 years ago died from cardiovascular disease in India alone. Now, we're talking about a quarter of the world's population, but 60% of the world's heart disease. Some of the work published by CARE's own Dr. Palaniappan, Lata's work in California showed that South Asians are having 4 times the rate of cardiac events, and these events are happening 11 years earlier in life. So you would think that we should do better after that heart attack. We're younger, but actually we have a 40% higher mortality from that first heart attack, even though we are younger when it happens. So what's going on, and how do we stem this bleeding, essentially, of major events happening at a much higher rate in a young South Asian population? Well, let's look at some little more data to prove that this is happening. Well, that traditional risk score that you saw, we know that the rates of heart disease are much higher in South Asians, but compared to other populations. But what are the risk scores showing? Well, as we just saw, the risk scores are almost identical when you calculate them. So the risk scores are terrible, basically, is what this is saying, in predicting events in South Asians. Even if you use the more modern QRIS-3 model, which includes South Asian corrections, it's still not showing us that difference in actual event rates. It's still missing big chunks of the cardiovascular risk in our population. Similarly here, the observed rate versus the predicted rate is much higher in South Asians, but we're pretty darn good at predicting that in white patients. So we really do need much better models that are including maybe new types of risk factors. And that was really one of the major motivations for me to start the SSATHI clinic, because when you look across the landscape of the US, right now there are only 2 cardiology clinics in the US that are dedicated to seeing only South Asian patients. Now, what are these risk factors that I'm talking about? What's the non-traditional risk that I'm speaking to? What we see here are 3 big buckets. And the first one you may have heard of before, which is insulin resistance and prediabetes. You've heard about diabetes, and that is definitely a risk factor for all patients, including South Asians. But prediabetes and insulin resistance are stepping stones to diabetes. The second bucket of risk is something called inflammation. And we could check 30, 40 different inflammatory markers. And there are some centers that when they screen patients, they just do a shotgun approach and they will check 40 different inflammatory markers. But the problem is you really need to choose ones that are linked directly to heart disease, that are prevalent in South Asians. And these are 2 examples right here on the screen. Lp(a) or lipoprotein A, and apolipoprotein B100 or ApoB. So these are the kind of 2 culprits that are rarely tested for in the general population, but every patient in SSATHI gets this tested at least once. Lp(a) is genetically mediated. ApoB, there is some genetic linkage to how much you have in relation to LDL, but it largely tracks with your bad cholesterol levels up and down. Now the good news is that we can actually treat this. If we lower LDL in a patient, we can lower ApoB. But with Lp(a), it's genetic, and if we try to lower LDL, we will still have high levels of Lp(a). But right now, we're testing new treatments that can specifically lower Lp(a) that will read out probably next year sometime. And so there is a lot of hope on the horizon for the South Asian population. We started the Stanford South Asian Translational Heart Initiative in 2014 to do personalized risk reduction. Seeing 1 or 2 of the doctor visits, sometimes 2 to 3 of the dietitian visits, and they weren't getting better. They weren't reducing their risk. We were only converting patients to a lower risk level 40 to 50% of the time, and that wasn't good enough for me. So in 2017, we realized through surveys and just observation that patients just didn't want to commute. So I launched CardioClick at that time, which is a fully virtual form of the SSATHI clinic. So what is SSATHI? SSATHI is a targeted heart risk assessment program to move the needle on this epidemic. We start by checking these non-traditional risk factors. So we use these non-traditional risk factors along with the traditional stuff, high blood pressure, diabetes, smoking, obesity that you've all heard of, to actually craft an actionable plan. We do an adjusted risk score for patients that we think captures the rest of that curve that you saw, that difference in predicted versus actual event rates. We actually create our own risk score that trues that up to what we think is actually going to happen to our patients. So is it working? And the answer is yes, it is working. And we see over 90% of our patients reclassified to a lower risk level in 6 months, which is really something we're very proud of, very impressive. So I really want to emphasize, like, as you're looking at this information, like, what should you do? If you haven't been screened for your South Asian specific risk factors, you need to do that. And not just you, but your wife and your husband and potentially your children, depending on their ages and stages of life. If you have a family history, which many of you do, of heart disease or stroke, this is even more important. So getting your family screened, getting yourself screened is the first step.